Hello, I'm Tony DeMaria, and I'm here at the American Heart Association meetings, and I'm sitting with Dr. Sharif Naga. And Sharif is Professor of Medicine and Associate Director of the Echocardiography Laboratory at the Methodist DeBakey Heart Center in Houston. And we're talking about a fascinating topic, which is the role of mechanical dyssynchrony. And actually, we, in a recent article of JACC, have featured Sharif and Dr. David Cass in talking about the potential role of dyssynchrony in guiding clinical care. So, Sharif, perhaps you could review for us how mechanical dyssynchrony has become such an important thing to measure in clinical cardiology.
Mechanical dyssynchrony, in the light of the cardiac resynchronization therapy, availability for increasing patients with heart failure, people have looked at whether the visualization of mechanical dyssynchrony can help identify patients who are more likely to respond to this therapy. This is an expensive therapy that carries its risks, so carefully selecting the therapy to the patients most likely to benefit is a good idea.
Well, and the early studies clearly have shown that you could use the presence of mechanical dyssynchrony, usually identified by cardiac ultrasound, by tissue Doppler, to predict those patients who were likely to benefit from biventricular pacing. Isn't that correct?
This is correct. There have been many methods applied, even earlier than tissue Doppler with MO, 2D, and so forth. The ones that have the most data as far as published literature are using tissue Doppler imaging. Particularly, there are two techniques, one looking at the opposite wall delay, and the other one is a measure of the spread of the timing in different segments of the heart, or the U-index.
Well, I've been impressed that the studies really have shown some predictive value, but it started with patients who had heart failure and wide QRS complex, and then wide but narrower QRS complex, and increasingly we began to recognize dyssynchrony, mechanical dyssynchrony, in patients who didn't even have wide QRS complexes with narrow QRS complexes, and then diastolic dyssynchrony entered the question. How are we to reconcile this sudden explosion of dyssynchrony and how to use it to make decisions?
I think the first thing one has to distinguish, or really not a distinguish, but state that not all cases of dyssynchrony are cases that should be referred or are good candidates for resynchronization therapy. Recognizing that dyssynchrony is present is an important thing, but it not necessarily means that you have to act upon it. It tells us that there may be a worse outcome for these patients, but it doesn't explain why the dyssynchrony is present without looking at the global picture of the patient. What I mean by that is one needs to look at all the data that is present as far as history and clinical presentation and other echocardiographic findings and move forward from that.
Well, the recent Prospect trial really showed some disappointing results in terms of using dyssynchrony to predict responders to resynchronization therapy.
I agree with you, Dr. DeMaria, and a lot of the reason has to do with how difficult it is to acquire the images and also the interpretation, even among experts. There are many signals that can be measured. There are several approaches that can be measured. When one goes back to the earlier studies, these were observational studies, albeit on fewer patients than larger studies. And that's one challenge. It is incumbent upon physicians who are interested in this field to get to learn more about it and have more hands-on experience and enough analysis so that they are more comfortable with it. Notwithstanding the Prospect trial results, I think it is what is being identified by as mechanical dyssynchrony by imaging is important, and we need to move into getting more specific data with what methods to use and how to apply them.
So just to wrap up then, do you think that the detection of dyssynchrony by cardiac ultrasound or any other technique at the moment has a clear-cut clinical role in guiding therapy in patients with congestive heart failure?
I think at the present time, yes. there is a clear-cut role, mostly for patients with a wide QRS complex who may not be good candidates for an implantation of a device for other reasons. Understanding whether there is dyssynchrony, mechanical dyssynchrony that is caused by a conduction problem or with a opposite wall delay type of etiology as opposed to previous infarction or ischemia is something that one can look at. It is not the only piece of the puzzle or the only piece of assessment that is needed. A lot of other data needs to come in and to be factored. For the other groups, data is definitely at an early stage and more needs to be looked at.
Well, certainly we'll be anxious to follow this explosion of dyssynchrony as time goes by and to see if really we can use this mechanical abnormality to help us treat our patients. Thanks very much for being here.
Thank you, Dr. DeMaria. Appreciate it.